If you said C, then you are correct. This patient has aortic stenosis. It is most commonly caused by age-related calcification. Presence of a bicuspid aortic valve increases the risk of aortic stenosis developing at an early age. Symptoms include angina, syncope, and the development of left-sided heart failure as the left ventricle tries to pump against the stenotic valve. Aortic stenosis is characterized by a systolic crescendo-decrescendo murmur best heard at the right upper sternal border that radiates to the carotids. Echocardiogram is used to confirm diagnosis and to estimate the valve area, which influences how aortic stenosis can be managed. Mild to moderate aortic stenosis can be managed medically by decreasing the afterload with ACE inhibitors, ARBs, and calcium channel blockers. Beta blockers may also be used, but should not be used in severe AS. Statins have been shown to help slow progression of valvular calcification. Patients with aortic stenosis often have concurrent coronary artery disease and are often also treated with antiplatelet therapies like aspirin. Valve replacement is indicated for symptomatic AS of any severity or for severe AS regardless of symptoms. This can be done via traditional surgical aortic valve replacement and may be done concurrently with coronary artery bypass grafting if the patient also has indications for a CABG. Aortic valve replacement can also be done with a newer, less invasive procedure called transcatheter aortic valve replacement, or TAVR, which does not require sternotomy. Instead, the valve is deployed using intravascular catheters. Aortic stenosis is one of the most common reasons for patients to undergo valve replacement. Prosthetic valves can be either bioprosthetic, meaning made with donor or porcine valve tissue, or mechanical. Bioprosthetic valves do not require anticoagulation, but degrade more easily, and so are more commonly used in older patients with a shorter future life expectancy, or in those with increased bleeding risks. Mechanical valves last longer, but require lifelong anticoagulation with warfarin, so they are more commonly used in younger patients. Direct anticoagulants like apixaban, rivaroxaban, and dabigatran have been studied in clinical trials for use in valve replacement, but their use is still controversial. So on an exam, the answer will still be warfarin. You may see questions about the need for prophylactic antibiotics for patients with valve replacements undergoing other procedures. In most cases, the answer will be no. The only situation when prophylactic antibiotics may be indicated is when a patient has a prosthetic valve or prosthetic repaired congenital heart defect, including annular rings and mitral clips, a history of prior endocarditis, or unrepaired cyanotic congenital heart disease, and they're about to undergo a dental procedure. For non-dental procedures, including orthopedic surgeries and joint replacements, prophylaxis is not required. Click through to listen to an aortic stenosis murmur, and then on to some rapid-fire questions.